Okay. Good morning, everyone. You hear me okay, I'm hoping. So it's a pleasure talking today, and I want to thank the organizer for inviting me to talk today. One second. So, as you all know, and I just want to remind us that Chiari malformation is probably a phenotype of various acquired congenital conditions. And today I'd like to make the point that tethered cord is one of them. So my talk will be talking first about like some historical and literature evidence where people were already thinking that tethered cord syndrome might be a relevant problem in Chiari malformations. And then I will give some case presentations from own experiences, my own practice, where classical tethered cord or occult tethered cord is associated with Chiari, and then even how this plays out in hypermobile EDS. I'd like to propose a decision tree and an algorithm how we can work up the tethered cord comorbidity in Chiari malformation, and then we'll present some of our research on the histopathology of the phylum and the connective tissue in people with Chiari with and without connective tissue disorders that can help us to understand the conundrum. So busy slide, but in the 2000, there was an interesting article published by Oakes and his group, where they found that there isn't really a relationship between Chiari, ectopia, and the Conus level. However, in those that had a lower Conus level, like below the L2, 3 number space, they found the Syrinx associated with the Chiari. So this is kind of a hint that tethered cord, if it's radiographically evident, might in fact worsen the spinal fluid dynamics, because the Chiari plus Syringomyelia is certainly more evidence that there's something wrong with the CSF circulation, and the tethered cord might have contributed to that. Then it went on in 2005 by an orthopedic group, interesting, where Chiari, Syringomyelia, back pain, and tethered cord. A little bit what Dr. Levy was mentioning in his talk earlier. And they found that after sectioning of the phylum, the conus actually had risen. And the scoliosis had gotten better. So curve reduction was noticed. And I want to get back to that later, the headache in those with Chiari malformation had disappeared. So again, some functional indication that tethered cord does something clinically relevant to the person with the improved headaches. So we cannot shy away from that. Next thing is the pioneering study published by Bolognese and Millerad. They did the pioneering work looking at Chiari malformation and tethered cord, where they found that those people with a low-lying conus and Chiari 1 malformation had a opposite finding compared to those with classical Chiari. So they had a wide skull base, and they didn't have like a reduction of the skull base. So they were already indicating that those might be different group where the sectioning of the phylum actually indicated to alleviate the Chiari malformation. Then there were some case reports where Chiari malformation was associated with a fatty phylum, and then Chiari and Symptomatic or split cord malformation. So there was a lot of activity going on, and I want to spend some time on the pioneering work of Dr. Millerad and Bolognese, because they actually provided some interesting cases where one could possibly believe now that what they sort of caudal traction theory. So the way how the caudal traction theory came up was by the belief that in our embryonic time, the settling in of the phylum terminale, which is the embryonic tail, might also cause disturbances of the cranial setting. And that's how the phylum pathology and Chiari might be linked through an embryonic, caudal traction. So they had three examples, very interesting. And I picked those examples from that paper, and I hope that's okay. So they had one woman, 20-year-old, who had Chiari malformation, as you can see here. But it was an example where the foramen magnum, defined by the anterior clivus, connected to the opistheon, which is a suboccipital bone. I'm sure you heard about all that anatomy in previous times. It's huge, wide, it's very wide, and not narrow like in classical Chiari malformation, but you have a narrow, steep, and narrow posterior fossa. So they did a phylum terminale transection, and after 8 months, see how all the anatomy has improved. Kind of what they wanted to propose with their paper. This is a gentleman that had a Chiari decompression. You see a film, unfortunately, too familiar to many, with the cerebellar ptosis and herniation, and they found a low-lying conus, did a phylum transection, and the ptosis had improved. Again, connection to the phylum and the Chiari. And then a 8-year-old female, after Chiari decompression for a cervical syrinx, which the syrinx didn't improve, and the child was still symptomatic. There was a low-lying conus, and they did a phylum transection, and you can see here the improvement of the syrinx. I leave that uncommented because I don't want to conclude anything. I just think that these examples are showing, that there is a subpopulation that in fact has an association with phylum terminale and Chiari, or Hindberg herniation. So the conclusion made by Millerad and Bolognese was that there is a subset that might in fact benefit from tethered cord surgery or phylum transection instead of doing the Chiari surgery. Certainly they say if there is significant tonsillar herniation, the tethered cord release could also cause like further Chiari settling by the release of the spinal fluid in the lumbar area. So, and certainly they were kind of guarded, commending phylum transection with no evidence of tethered cord by the imaging, which is defined by low-lying conus or fatty phylum. But what was interesting, and I want to get back to that later, they did some fancy ultrasound studies before detethering in those patients. And they found that the phylum is dorsally retracted as a sign of this tethering. They saw the phylum here caught and pushed against the dura. And they also found the nerve roots kind of pushed aside, almost like a pressure buildup. And then when they did the release, they saw that I jumped to this here. So on the right side, so this is pre-surgery, phylum retracted dorsally, nerve roots like kind of squished laterally or pushed. And then after release, then the rest of the phylum kind of moved ventrally as a relaxed sign, and the nerves were kind of scattered again as a sign of normal cauda-equina rearrangement. So they found that there are also some spinal fluid dynamics going on down there at the phylum side. I'm going to get back to that later. Unfortunately, the 2011, there was some, concern with a lot of controversial evidence. Rocco and his group said that there couldn't really be any proof of the caudal traction theory because some clinical and experimental evidence doesn't support it. They looked at they reviewed it, and there were some non-human primate MRI studies that they say that the conus actually doesn't really move, and then some cadaver studies where they pulled at the cord or at the phylum, and they didn't see that this does anything to the tonsils of the cerebellum. But you know, it's difficult to judge certainly physiology and real life scenario in the MRI studies and cadaver studies, because these are not always the biomarker. So I think the negative evidence should be looked at in a guarded fashion. But interesting, the same year, 2011 again, a group in Italy also found that when you did tethered cord release in lipomas or fatty phylum, like a classical tethered cord, there wasn't really a change of the tonsil position after a year after the detethering. So people were kind of trying to prove, but it was hard because of the missing biomarker that would eventually help us to understand. I'm going to bring in the next like 5 minutes, and I go through that quickly, some presentations of my own practice before I talk to like some elements of like how we can work that up in the future. So case 1 is a patient with like a syndromic association of Chiari malformation and a fatty phylum. As we know that there are some syndromes, for example, the Vacter syndrome, which has a high prevalence of tethered cord and Chiari malformation. And often these patients present with both headaches, back pain, leg weakness, and urinary retention. So here we have to assume that both pathologies are equally relevant. And so in this patient, we did a suboccipital decompression, and then 7 days later, a phylum transection. And there are, in terms of timing, you know, even though there's no consensus at all up front, but Brim and his group actually, in a subgroup of their patient population, advocated that if Chiari and tethered cord are equally clinically relevant, you might do those surgeries even simultaneously or close to each other, because there's some benefits to address both of them if the symptoms are just progressive. And you can read that abstract. I'm sure my talk will be on YouTube. The second case is a patient that actually was referred to me for Chiari. She had a migraine type headaches with pressure headaches in the suboccipital region. And the pediatric neurology worked her up, of course, for migraines. Medical management was exhausted. And so this was a brain MRI, a spine MRI. It says that there was some 5 to 4 millimeter tonsillar ectopia and some crowding in the posterior fossa. So there was some indication, and then sent to me. And when I saw that girl, of course she had this headaches, like her head is in a vice, and but then she also told me that she has some pressure on her chest. She cannot breathe because her thoracic spine is painful. She explained to me all those symptoms that we usually hear in tethered cord syndrome, with weakness in her legs, restlessness of her legs, and also she had some developmental delay, clumsiness since her early childhood. And then also, since she saw the neurologist, she also complained to him already about like abnormal feeling in her bladder. She didn't feel that her bladder fills up, and sometimes all of a sudden she has the urge to go. Her exams showed some asymmetric weakness on her legs and some clonus, which could be a sign of cord traction. I did an MRI, and she had a borderline low-lying conus. You see here the tip of the conus at the L2-3 level, which is borderline low. And so we did a phylum transection because of her symptoms of her bladder symptoms. She actually had, upon the laminotomy, oops, sorry about that, upon the opening of the dura, a tight and big phylum with the central canal actually going into the phylum. And that is under debate, but the extension of the central canal into the phylum might already be indicative of an abnormal embryonic phylum that has some problems, you know, with its spinal fluid content, and might be abnormally structured, pathologically affecting phylum. So we did histology, and you can see here the ependymal canal extending into the phylum, lots of ependyma, which is certainly abnormal tissue and abnormal embryonic findings in the phylum. So her headaches resolved, it's post 1 month post-op, of course, but her pressure feeling has resolved pretty immediately, and also the pressure in her thoracic spine, almost like her spinal migraines had resolved. And I sometimes wonder whether tethered cord actually caused spinal migraines. Her leg pain and weakness resolved, and she was already running on the beach and was canoeing this weekend, which was certainly like quite a gain. Case 3 is a lady with hypermobile EDS. She had a genetic evaluation. She did have also signs of occult tethered cord with weakness in ambulation, leg crampes, back pain, lower back pain, and lower extremity hyperreflexia. But she had mainly symptoms in her upper body with positive Valsalva sign, coughing and sneezing caused a lot of pressure. This was her findings. Now, Conus was as a normal level, L1, but she had a lot of cognitive decline, headaches, and no bladder symptoms. Given the cognitive decline, and I know Dr. Grant talked about the cognition and the Chiari, which we wholeheartedly support, we did Chiari decompression. She had quite some arachnoid obstruction. This is the opening of the dura. You can see here the arachnoid, you know, causing a lot of webbing to the tonsils. This is a spinal cord. These are the tonsils. And you can see here a significant arachnoid obstruction. That is one reason to probably do a durotomy Chiari, because arachnoid might be an element of obstruction. And even after opening the dura, the arachnoid was kind of like really glued or scarred to the tonsils. So her headaches resolved post 6 months, and her memory had gotten better. She is a high functioning lady, and she actually never thought of how bad her memory and her focus was. And she's awaiting follow-up cognitive testing. The last case, before we talk about the algorithm, is actually a lady that also had both procedures pretty close to each other. She had the Chiari surgery first because of significant Chiari symptoms, but then at the same time, when I saw her first, she had a lot of tethered cord symptoms with the legs feeling heavy, and then also she had given up running. When she sits for a while, her legs and feet are in pain. She stiffens up. She has this deep pain in her lower back, and her feet get cramped and curled, like things that you really hear when you evaluate someone for cord syndrome. This is for imaging the Chiari, as you can see here, with crowding of the foramen magnum. She had a cervical syrinx. I don't see it well, but this is the thoracic MRI, and then the axial cut through this area where you can see the syrinx. That's one reason why we addressed the Chiari first, and then Her lumbar MRI is pretty much occult and doesn't show a low-lying conus, any abnormal phylum signal. But the suboccipital decompression was done first for the cervical syrinx, and her significant debilitating headaches that were Valsalva positive. Then shortly after, she declined with her bladder function. She did have a pre-op urodynamic study that showed increased EMG activity in the detrusor muscle consistent with neurogenic bladder. And so we weren't shy of even 3 months post-suboccipital decompression to also resection her phylum because of the positive bladder study and the decline in her urological symptoms shortly after. I leave it as it is, but you can see how the suboccipital area and the base of the spine kind of go together. I want to be mindful of the time. There is, dynamically must be an association that we might not understand yet, but we have to certainly look at it. So the decision tree for now is that if there's a patient symptomatic from Chiari, perform full spine to look for Syringomyelia at the upper spine, lower spine, which might be more a hint of something going on with the phylum or more with the skull base. And then if there is symptomatic Chiari, even if there's no radiographic evidence of tethered cord symptom MRI, you would still look at tethered cord symptoms. And I make it quick. I presented this last year at the conference. This is our decision tree for tethered cord and occult tethered cord, looking at the triad of urodynamic findings, neurocutaneous findings, lower leg, neurological abnormalities, and back pain, scoliosis, positive finding in the bladder study. We certainly embrace comorbidities. And then if those are positive, and progressive within the last 6 months, you go to surgical tethering. Otherwise, you would monitor. And I started to apply those algorithms to every symptomatic Chiari patient to not overlook the comorbidity of tethered cord. And I think a prospective study is warranted. I told you about the importance of the bladder study, which, like the underactivity and the detrusors overactivity and the detrusor sphincter, the synergia, are relevant neurogenic findings. I don't want to get too much into craniocervic instability because people always ask me, does the tethered cord release help the instability, particularly people with connective tissue disorders? For now, I have to say it goes both ways, and we have no evidence of yet unless someone tells me otherwise. Let me spend the last 5 minutes, so we have time for our panel, on our research that hopefully helps to connect the dots and cross the T's and put the dots on the I's. So there are two things. What other researchers that even weren't necessarily looking at the phylum terminale found out, which might apply to what we see here in the connection of Chiari and tethered cord. And that gets me back to what Bolognese and Milroy found about, like the dynamic changes that go on in the thecal sac with all that pressure buildup. So there are embryonic studies that show that in the embryo, there is a connection between the ventricles and the base of the spine and spinal cord through the central canal. And the fibers that control the pressure of the ventricles, called Reissner fibers, they go all down to the central canal in the spinal cord. And then I just showed you that the central canal extended to the phylum. And actually, cadaver studies in humans have shown that down in the phylum, in the central canal in the spine, there are Reissner fibers. Reissner fibers control the pressure of the spinal fluid. So it might as well that the phylum is also controlling some of the CSF pressure that sure is not just happening down the spine, but might have some implication on the pressure of the skull base, even in the ventricles. So sometimes we're surprised that people have improved headaches after phylum resection because you kind of change that nature as well. And here I think, you know, I just want to connect what Dr. Bolognese found with what recent thoughts are. And then certainly, you know, collagen is probably the overarching connecting pathology. It might be that we are not only having problem with our collagen in the phylum, which we found out, I presented it last year, all the corkscrewing and the disintegration of the collagen, mainly seen in people with tethered cord syndrome with EDS, all the badness on the collagen, bleeding, corkscrewing, swelling, disorganization was found in 83%, you know, in the EDS patients. Or let's say of those that had abnormal collagen, 83% were EDS tethered cord patients, only a few non-EDS. So it might be that we are onto something with the collagen. Remember that lady with EDS that I presented to you that had like the improved headaches after Chiari decompression? In our new IRB, we look at the connective tissue disorder, connective tissue that you can take from what you take anyways when you do a Chiari decompression. We all have that epidural band that's right below the suboccipital bone. And these are elements of connective tissue that are connected to our suboccipital muscles, also called myodural bridges. So we looked at this connective tissue disorder in this lady. You see here an example where the ultrastructural specimen was taken from those connective tissues, and you see totally abnormal corkscrewing of the collagen and bleeding, pretty much what we found in the phylum. So there might be a connection in abnormal connective tissue incompetence in the skull base and also at the base of the spine. This is normal collagen in a non-EDS Chiari patient. I'd want to acknowledge the team, and particularly my postdoc, research fellow, Abby McElroy, who just did all the histological analysis and relates to our work that we do in the equine model, where we also looked at the myodural bridges and found connective tissue abnormalities. This is hopefully food for research, and here I would like to end my talk and certainly open to questions. Thanks a lot. Thanks for having me.